Yeah, thanks for the introduction. I'm going to be talking about the following subject, a tale of two cysts, which actually just refers to pneumocystis jirovecii pneumonia in two different manifestations, one in HIV positive and the other in HIV negative individuals. I learned a lot about the topic while reading on it, and I thought it was very interesting because it kind of tells us that difficulties in understanding the immunopathology of pneumocystis kind of prevent us from really managing patients, particularly HIV negative individuals with pneumocystis pneumonia adequately. So that's why I thought it would be an interesting topic. The case is actually a case that the fellow in ID, Tari Papavarnava, saw together with the hematological team a while ago. It's a 17-year-old female who in August of 2021 was diagnosed with AML and myelodysplasia, and who was treated initially with fludarabine, cytarabine, and mitoxantrone. Sorry, the history is very brief. On the 26th of January of 2022, she underwent an allogeneic stem cell transplant, which was complicated shortly thereafter by neutropenic fever, for which she was initially treated with piptaz-amic, which was then changed to meropenem when she developed what looked like septic shock. She initially did well and recovered from that, but then approximately a week later, while still admitted, she developed a fever and new respiratory symptoms. And at that point, a repeat chest X-ray and CT of the chest were done. And both kind of show some subtle ground glass opacification in both lungs, which was deemed to be suspicious for potential pneumocystis pneumonia. But as you can see, there's a large differential. And this is really typical to patients with underlying immunodeficiencies other than HIV, in which the differential diagnosis is probably a little bit smaller, and the pretest likelihood of pneumocystis pneumonia is a bit higher. But it is an important diagnosis on the list, and it's relevant to this case because the patient was initially started on treatment for pneumocystis pneumonia. And this kind of brings me to a discussion of the topic in general. So basically, pneumocystis jirovecii, as we now call it, was an organism initially classified as a protozoan, but several decades ago reclassified as a fungus based on DNA sequence homology, which was closer to fungi than to protozoans. It is a yeast-like fungus that exists in a trophic and cystic form, and the cyst or the ascus holds up to 8 sporozoites, which can then go out of the cyst and become trophic forms. Interesting about pneumocystis is that mammals are the only really known host, and species are actually totally host specific and seem to have evolved closely to be able to thrive and survive in the pulmonary biological environment of their host. So to humans, pneumocystis jirovecii is the specific pathogen, and in rats that is Carinii, and in mice that is pneumocystis murina. So this brings me kind of to the discussion of pneumocystis and its relation with the host. So like I said, pneumocystis species are completely specific to a host. And from the research that we know so far, it looks like it's an obligate pulmonary pathogen. There's no real clear environmental reservoir. There were some studies pointing perhaps to soil, but that has not really been consistently found. And it looks like the only actual source of the pathogen can be found in the host lungs. And because the environment in which the pathogen can survive is so specific, you can imagine that it's very hard to create an in vitro culturing system that really works, and that's why we don't have one. And in humans, pneumocystis jirovecii colonization is almost universal, as illustrated by very high seroprevalence rates, which have been observed in young children. And it looks, if you think that the host respiratory tree is the only real reservoir, that there has to be human-to-human transmission. And this has indeed been substantiated by studies showing outbreaks in hospitals, for instance, in hematological wards, for instance. And there is a lot of debate around this, but it is unclear whether pneumocystis disease is due to reactivation from a previously present pathogen or because of a new infection. And it looks like maybe new infections are a more important source, but we don't know that for sure. I want to briefly discuss the immunopathology because it's very important, but it's important to take everything I say here with a grain of salt because it is a very contentious subject. And I'll be basing most of my comments on this review by Charpentier et al. Published last year, French research group. What is very clear and what we know from HIV is that in the CD4 positive T cell obviously plays a critical role in the clearance or control of pneumocystis. And what we also know, and this is basically from rat and mice model studies, is that the primary mechanism of importance is the coactivation signals between the CD4 positive T cell and the B cell that you all remember from like your med school immunology classes. And it is very interesting that actually the B cell seems to play a very important role. Firstly, B cells are antigen presenting cells and can thus present elements of the fungal antigen for MHC2 activation of CD4 helper T cells. But also after initial presentation to the helper T cell, the B cell provides the coactivation signal that leads to T cell activation and differentiation. And from models, it's been shown that the T helper 1, 2, and 17 responses are all induced. And as a result, it's a little bit difficult to say which response kind of does the work. And it looks like it's a balance between these responses that ultimately leads to clearance in immunocompetent people, but we don't know exactly the individual contributions of those responses. What we do know is that Th2 responses seem to be very important, as also shown on the graph. The T helper 2 response leads to alternate or M2 macrophage activation and eosinophil activation. And those two cells together seem to be able to clear pneumocystis without requiring much help from the typical cytotoxic cells, so the CD8 T cell and the neutrophil. And what we also know, again, from animal models, is that the B cell seems to be important in another way because antibody production itself also seems to directly contribute to clearance to an extent. So this is in the healthy subject. So what happens in an immunocompromised subject? Now, in immunocompromised and in our setting, that is mainly HIV, we primarily deal with an impairment of T cell count and function. And as a result, this primary axis of CD4 and B cell crosstalk and activation can't really happen functionally. And as a result, because control of the pneumocystis doesn't happen, pneumocystis tends to accumulate in the alveoli up to high numbers. And eventually numbers are so high that this leads to a more classical cytotoxic response by CD8 T cells and natural killer cells. And this cytotoxic response is basically ineffective. It is excessively harmful and doesn't really lead to effective clearance, but it does lead to a whole lot of tissue inflammation and damage. And this kind of correlates well with the clinical things we know about pneumocystis and the extensive lung damage that we see on imaging. This also informs our management of pneumocystis pneumonia in HIV-positive patients, where we target both the pathogen using the antimicrobials that we all know. There are several regimens for that, but that also targets the host immune response using corticosteroids. And that is based on good clinical trial evidence from early in the HIV pandemic in hypoxic patients with AIDS, in which adjuvant corticosteroid treatment seemed to confer a mortality benefit of approximately 50% when given. However, something new is afoot, and there's an epidemiological shift going on, basically in the epidemiology of pneumocystis pneumonia. This is a study from a group in Lyon, France, by Bienvenue et al., which looked at a single center cohort, large cohort of pneumocystis patients from the early 2000s, and they mapped out the underlying pathology over time. And as you can see, whereas in the early 2000s, the distribution was approximately 50-50, the contribution of HIV positive patients to pneumocystis pneumonia diagnosis gradually dropped to below 20% and was taken over by the number of HIV-negative patients with pneumocystis, which quite rapidly rose. And that trend of a dropping prevalence of pneumocystis in HIV-positive patients can also, of course, be explained by greater access to ART, and is a trend that has been observed globally. And Prof. Mendelssohn and Wasserman from the ID group have also described this in a review for the African setting. The fact that HIV-negative pneumocystis cases are going up might be because of increased use of specific immunosuppressant treatments, or, for instance, due to increased recognition of the disease. And we don't really know, but it would be interesting to find out if this trend is also happening in African countries. We do know that there are a lot of established risk factors other than HIV for pneumocystis pneumonia. And I mean, we all know that CD4 count depletion and chronic high-dose corticosteroid use are contributing, but there is an array of other factors at play. We know that various specific immunosuppressant drugs can lead to pneumocystis. And interestingly, rituximab is often seen as a cause, and that kind of leads you back to the importance of B cells in the immunology, because rituximab is an anti-B cell agent. For our hematological colleagues, it's important to note that obviously there are several, as you well know, hematological malignancies and treatments that can cause or predispose a person to getting pneumocystis. And it is poorly known whether it's the malignancy or the treatment, and probably both, that leads to this. But what we do know from a recent publication from Spain is that in their cohort of HIV-negative patients with pneumocystis, the most prevalent risk factor was actually that of hematological malignancy. Now, for us clinicians, what is important to note is that the clinical characteristics of pneumocystis pneumonia are very different from the HIV-positive patient that we usually deal with to the HIV-negative patient. From a disease perspective, what we know is that in HIV-positive patients, the fungal burden is very high. And in HIV-negative patients, it's overall lower. And that is in contrast to the inflammation component as shown in amount of neutrophils visible in bronchoalveolar lavage fluid, which is much lower in HIV-positive patients, but higher in HIV-negative patients with pneumocystis, pointing us towards the idea that the immunopathogenesis in HIV-negative patients is more that of inflammatory overactivity than primarily caused by a fungal burden. In terms of pulmonary features, we can see that damage to the lung seems to be more severe in the HIV-negative population, which in most reviews presents with lower PaO2s at baseline and with more dense ground glass and more apparent consolidations on imaging. And that is reflected in the clinical course of these patients. And we know that in HIV-positive patients, pneumocystis is already a severe disease. But in HIV-negative patients, again, according to case series, the clinical presentation tends to be more acute and mortality tends to be much higher. Now, given what I told you about this quite severe disease course of pneumocystis in non-HIV patients, I wanted to take you on a small journey through two crucial questions that I found during my research of the literature. One is basically how to diagnose pneumocystis pneumonia in non-HIV patients, and I wanted to focus there on the role of PCR. And the second is how to treat pneumocystis, and to particularly focus there on the role of adjuvant steroids. So regarding the first question, how to diagnose pneumocystis and how we use the PCR in that respect. What we know is that in non-HIV patients, the clinical presentation in most case series is more atypical and is accompanied also by a larger differential diagnosis, which makes it harder to treat patients based on clinical findings alone. And also, as I said before, there's a lower fungal burden in the lungs and on bronchoalveolar lavage. So therefore, as said, diagnosis is more challenging on clinical grounds alone. But because of the low fungal burden, a direct visualization message, such as a microscopy of the bowel and DFAT, is often negative. And therefore, we rely more heavily on molecular methods, which are more sensitive to identify the pathogen. And this is illustrated by, again, this large case series of pneumocystis patients from France that show that in patients who have a diagnosis of pneumocystis made with microscopy, the majority of those patients was HIV positive. And in patients where the diagnosis was based on PCR alone, those patients were HIV negative in the far majority. So because of this differential fungal burden and because we need more sensitive measures, a quantitative PCR might be important in detecting the pneumocystis. And what we know about quantitative PCR is that it has an excellent negative predictive value if there is no target detected, so i.e. if the qPCR is negative. However, if the target is detected, so if we find pneumocystis on the bowel, that gives us a problem, because we know, as said, that colonization is very common, and therefore that patients without pneumocystis pneumonia might still have detectable pneumocystis on bowel. And therefore, we need to come up with thresholds. And what several papers in the literature show, and this is just one example published in 2016, is that there's a drive towards setting different CT values for the HIV positive and the HIV negative population in using qPCR to help diagnose pneumocystis. And these authors did just that and showed that like the optimal CT value thresholds in HIV positive patients are much lower than in the red group than in HIV negative patients in the yellow group. However, one practical problem here is that targets used for qPCR for pneumocystis are diverse, and CT values are not always established and might depend on the target gene. So basically, to conclude the segment on diagnosis, in making the diagnosis of HIV negative pneumocystis pneumonia, we should take into account obviously clinical radiological findings, also the results of other important tests such as beta-glucan and other parameters. And we can use a negative qPCR as a rule-out test. But in case of a positive qPCR, the CT threshold becomes important. And quantitatively interpreting that qPCR result may be tricky and may be vulnerable to overcalling the disease due to colonization. So now for the second question, so how to treat, and specifically, can we use steroids in this population, as we so often do in HIV positive patients with pneumocystis? So I want to take you briefly through this recent paper, which is one of the largest retrospective single-center cohorts studying early corticosteroid treatment for pneumocystis in patients without HIV. And as you'll see later, there are no prospective studies, so retrospective evidence is really all we have. In this specific study, I believe from the US, patients were divided into, with pneumocystis pneumonia, were divided into an early steroids group, which is very large, 250 patients, in which steroids were given within 48 hours of diagnosis of pneumocystis pneumonia at a mean dose of 60 milligram prednisone for a mean duration of 7 days. The control group was a group that was not given steroids early. This group is much smaller. And importantly, in 1/3 of cases, steroids were actually still given, but only after 48 hours. And what is important to note, and that also becomes clear from this table here on the right, is that the group that was given early steroids had a worse baseline respiratory SOFA score and a lower PF ratio than patients to whom no early steroids were given, which might point us towards a provider bias. And in order to correct for this, in their retrospective cohort analysis, these authors did one analysis where they analyzed the full cohort, but adjusted it for the baseline SOFA score, which was worse in patients getting steroids early. But also they did a separate nested case control where they used propensity matching to see if they could really tease out the effect of steroids and cancel out any baseline differences between the groups. So the results of this are very interesting. And the primary result, or the headline result of this study, was that in the patients with early steroids, their improvement in the respiratory SOFA score by day 5 was actually worse. So patients who did not receive steroids tended to do better by day 5 in terms of their SOFA score improvement. And this remained significant after several adjustments and also in the propensity adjusted analysis. The authors then also did a secondary analysis looking at mortality and showed that there was actually a trend in patients towards increased mortality in the early steroids group. But this was neither statistically significant in the primary cohort analysis or in the propensity analysis, in the case control analysis with propensity, propensity weighing. But overall, these authors concluded that they could not discern any benefit from early steroids and potentially a trend towards worse outcomes. So how does this correlate to what other studies say? And there's a recent systematic analysis, meta-analysis that came out in 2020 by Ding et al., which incorporated a large amount of very small and all, unfortunately, retrospective studies. And in the overall population of non-HIV patients with pneumocystis, this review also found a statistically significant signal for harm when using steroid therapy in pneumocystis. However, in this review, a subset of studies with non-HIV patients with respiratory failure was also looked at. And here, a trend towards a benefit from steroids was seen in this hypoxic population. So it seems like, similar to the situation in, for instance, COVID, it seems like potentially steroids can have an effect in hypoxic patients. But we must take all of this with a grain of salt. And as you can see from the significant heterogeneity and retrospective nature of all of this study, we really need prospective data in order to have a more clear verdict on this. So it really leads us to a conundrum, though, because it is, to me, very puzzling why steroids don't work. And I think there's two options here. Either all the observations that we have seen are due to bias, and that could well be true, because it has been noted that steroids were often only withheld in these retrospective cohorts in cases of mild disease. And there might be potentially residual confounding despite adjustment for all kinds of baseline factors. But it could also be that steroids really don't work in this population, which again is surprising because, as I showed you before, the clinical features of the disease suggest that it's mainly an inflammatory problem, and you would think that steroids would be able to deal with that. So potentially the effect of steroids is blunted in this population because most of these patients are already on long-term steroid use before the onset of disease. Or alternatively, the fact that these patients so often use biologicals and other immunotherapy might blunt the effects of steroid adjuvant therapy. We could maybe discuss whether there's a potential role for more specifically targeted immunosuppression, which we also see could work in COVID pneumonia. But I think we really need prospective studies to know how to optimally treat this illness. And this leads me to my take-home messages. The first one is that pneumocystis in general is just poorly understood, and we really need to understand this disease more properly. Pneumocystis pneumonia in non-HIV patients has very poor outcomes. And the diagnostic approach in this patient subset relies more heavily on molecular testing. And from what we know to date, we think that steroids might not have a beneficial effect if we give it to this patient group. I'd like to acknowledge help from the following persons, and thank you all for your attention.
Thanks, Lucas. That was really fantastic, as always. Your talks are generally just really good, and this was no exception. You can stop sharing your screen so that we can have a little chat. Vernon and hematology colleagues, I'm not sure if you would like to comment on, I guess, firstly, the kind of incidence of pneumocystis in your patient population, because that's really what brought up this question and the reason for the presentation. We recognize it very commonly in HIV-positive patients as a cause of community-acquired pneumonia, but much less in patients with hematological cancer. So I'm interested in your experience, and then also what are the high-risk conditions that we should kind of be more, that this should be higher up in our differential diagnosis for patients with respiratory illness. So I'm not sure, Vernon or other colleagues, if you want to comment.
Sean, I'll make a quick few comments. Thanks very much. I think that was a great presentation, very, very interesting. Just first, something to think about. I was wondering the fact that steroids were not as effective in the non-HIV patient group. The non-HIV group is largely cancer patients, I think, especially, I think, as you showed, hematological malignancies, who might already be severely immunosuppressed with other means. Could be that the steroids tip them over to a state where they might actually become more vulnerable to other things and may make things worse in already very immune suppressed situations like the patient shown. Fludarabine should be highlighted. It's probably, and obviously all the other purine analogs, including cladribine, both of which is used in our setting. We use fludarabine a lot, cladribine somewhat, pentostatin not that much. As a matter of fact, actually not at all in Groote but all three of them put patients at high risk of PJP due to CD4 depletion. I think one of the reasons why we don't see that much is because we've come to learn how to work with these drugs over time, and patients receive prophylactic acyclovir, Bactrim, and all sorts of things for herpes zoster reactivation and PJP prevention. And I think that's probably it, but we will have to keep our eyes open. There's a number of new drugs on the horizon, BTK inhibitors, etc., that might change the world going forward, and we'll have to see what the risk of PJP is with some of these new agents. Thanks.
Thanks, Vernon. I mean, you mentioned prophylaxis. Can I just ask, because I mean, embarrassingly, I don't actually know. I mean, what is your protocol for cotrimoxazole prophylaxis? Which patient groups receive it? How is it given? At what stage is it given?
Sean, the protocols that I've typically used has been either Bactrim 1 tablet daily or 2 double strengths twice a week. I know some people use 3 times a week. I've mainly used the daily dose, and in some patients a twice weekly dose. I don't know if there's any evidence for one over the other.
And in what patient populations do you provide that?
I typically use, I failed to mention bendamustine. That's another one that's important. So it's mostly CLL patients and some lymphoma patients, especially those receiving the drugs that I've already mentioned. Yeah, and obviously HIV patients as well.
Thank you. Are there any other questions for Lucas or other comments?
Can I maybe also, Sean, can you guys hear us here in the seminar?
Yes.
Okay. Cecile, I just want to say that there are a few other situations. Obviously, in our allogeneic stem cell transplant patients, the recommendations is for the first 6 months post-allogeneic transplant, and then give the Bactrim as prognosis said. And the other group where it is also recommended is acute lymphoblastic leukemia, particularly in the first part of the treatment when they're always on steroids. So those would be the other ones to look out for. We've very seldom seen pneumocystis. I've personally only seen one in a transplant follow-up that stopped their Bactrim. And then we've had these cases where we've discussed with you guys and we've treated where we didn't prove it. And then I remember a few years ago, there was one patient who had fludarabine, and a few months after the fludarabine had pneumocystis. So it's very rare that we see it.
Yeah, thank you. Before we move on to Jonathan's talk, maybe if I can just ask someone from microbiology, and I'm looking at Hafsa here because pneumocystis is much more of an issue in pediatric populations, and Hafsa is a microbiologist that works at Red Cross. Just to tell us about the different diagnostic tests that are available to us.
Hi, Sean. Sorry, I'm struggling to unmute there. We don't have anything based at Groote here, but we refer out. So at Tygerberg, they can do a fluorescent assay looking for an antigen. And then in Johannesburg, we can do a PCR there.
Thanks. Do you know the details of the PCR that they offer in Johannesburg?
I'm not sure. Do you mean like if it's a quantitative or
yeah, what the target is, if it's a quantitative, what cutoffs they use?
Sorry, I'm not sure the details, but I think one of my other colleagues might know.
So I actually asked Chad this question yesterday, and he did look into it for us. I think it's the MSG gene, which is the target, and it's not really quantitatively validated in as far as he could tell me.
Yeah, so because of multiple copies of the gene, it's actually not possible with this particular assay to do quantitation or semi-quantitation. So they do apply the PCR results to a standard curve, but that's more for quality control purposes. And one of the questions was whether or not there were different cutoffs for different patient populations for this particular assay, or according to our SOP, but apparently there's just a single cutoff and no differentiation between colonization or true infection or subgroups or within subgroups.
Thanks, Chad. Thanks, Hafsa. And thank you, Lucas. I mean, there's clearly a lot more questions that we have around this fascinating disease that we know actually surprisingly very little about. And hopefully those are going to be addressed soon. So Lucas, that was fantastic.